Hey y'all, it's Dr. Shelley with HETV, and I hope you're ready for part 2. Part 1 was external fetal monitoring, NST, biophysical profile, antenatal surveillance. Part 2 is just plain old Veal chop, where we can apply some principles here. Now, you know Veal chop is a mnemonic that kind of like everybody needs to learn, no matter if you're a medical student, nurse practitioner student, or nursing student. Every one of us learns Veal chop. Now, I have some strips on the board, and they are labeled strip A, strip B, strip C, strip D. Now, I'm going to give you a quickie quiz, and you're going to kind of cut me off so you don't hear the answers, but let's give you a couple of different patients, okay? Case study type of 1-question patients, okay? So your patient is a diabetic. She's poorly controlled. Her last ultrasound showed that her amniotic fluid volume was low, and she has poor prenatal care, and she has had high blood pressure for the last 10 years of her adult life. Which monitor strip do you anticipate possibly being her fetal heart rate strip during her labor? Is it A? Is it B? Is it C? Or is it D? If you answered B, you're correct. This is the worst monitor strip on the board, and diabetes is the worst condition you can have in pregnancy. And so I would expect some fetal distress since she's been hypertensive, poor prenatal care, poorly controlled diabetes, not much fluid around the baby. She's going to probably show some fetal distress, and we'll talk about that. The next patient is a gravitas 7, para 6. And she's coming in telling you her water broke in the car, and she's huffing and puffing, going and blowing. It's coming, and you better get ready because this baby is on its way. Which monitor strip do you think she's going to have? Would it be strip number A, strip number B, strip number C, or strip number D? Do, 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 do. That's my music while you think. Yeah. It's going to be strip number C, letter C, because she's going to have what's called early decelerations, where the decelerations actually mirror, they just look like they're upside down, they mirror the contraction. And that's because that baby's head is being pushed and it's coming. Let's do another one. Your patient was having some problems in pregnancy with domestic violence. And as it turns out, she was measuring smaller than we would like her to measure. Her fundal height at 40 weeks only measured 35. And so she was behind in her measurements the whole time. So the doctor ordered an ultrasound and found that she had oligohydramnios. So she is now approaching the hospital in labor. But right away, as soon as the nurse puts the external fetal monitor on the patient and the toco, she's definitely having contractions, and she's absolutely showing some changes in the heart rate that are reflective of what I said. So which one of these monitor strips are her? Is she strip number A? Is she strip number B, letter B? Or is she strip letter C or strip letter D? Do 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 do. She stripped letter D because without much amniotic fluid, every contraction that she has squeezes the cord. It compresses the cord and gives variable decelerations. Okay, that was a mini quiz. Let's jump to why all of this makes sense at the end of it, right? Let's go ahead and get started. We know that veal chop is the mnemonic. And did you know that you've got to line up your veal chop exactly the way I line mine up? The V and the C need to go together. Yeah, everything needs to line up. So let's take on the V and the C first, okay? The V stands for variable decels. And I want to remind you, because I told you earlier we were working in this packet, the maternity packet, in the part 1 part of this video. And I also mentioned to you that we are going to be looking towards the middle of the packet, and we're going to be looking at this page right here, taking some notes. So your veal chop can be put right on that page. Okay, that's in your packet. Now, we also told you we have a huge sale. 8 for $88 plus 3 of these specialty packets, your maternity, your pediatrics, and your growth and development for a total of 11 packets. All of that is fine for $99. Okay, so that's just a side note. But come on now, you need to get your shit together. So the variable decels, the V for variable decels, coincides with the C for cord compression. Okay, let's take a look at that. Variable decels, cord compression. These are the easiest ones to locate on the test, because if you look at the contraction, 1, 2, 3, 4 contractions, the fetal heart rate dipped down in the shape of a V each time, and the lowest part or the nadir part of the V matches the nadir or highest part of the contraction. The peak of the contraction matches the nadir of the fetal heart rate. In other words, these two kind of go together. The top of the contraction is the lowest part of the heart rate. Now, cord compression can occur with 2 different scenarios. Either there's not a lot of amniotic fluid volume to cushion the cord, or there's a cord around the neck, around the arm, around the foot. Children like bracelets and jewelry just like we do. And your baby might want their jewelry before they come out. And in that situation, it's a cord around the neck, which 1/3 of children have. It's actually kind of easy to take it off. But while they're inside of you, they can't get out of it. So every time they get this squeezy contraction, it's squeezing the cord. And sometimes that cord is around body parts, or the fluid is too low, because you see the fluid acts like a pillow. So if you take a look at my hand and you see there's many veins in the hand, if I press on that vein, I'm going to cut off significant blood flow to the area. And if I stayed there, I might even feel numb and tingly. If I put a pillow on top of there and tried to squeeze that vein through the pillow, that's what amniotic fluid is. It's a cushion. It's a pillow between the contraction and the baby's cord. That's all it is. And so when there is a, look at this, come here, stay with me. When there is a variable deceleration with contractions, it is cord compression. But get this, I take you a step further. The C also tells you what to do about it. Your first nursing action is to change maternal position. So if she's on her right, turn her on her left. If she's on her left, turn her on her right. If she's been both of those, put her on her hands and knees. Look, uterine placental resuscitation. Change maternal position, change maternal position. With variable D cells, it's the first nursing action, okay? So again, V for variable D cells, C for cord compression, C for change maternal position. I'm moving on. The next part of our veal chop is E and H. The E is early decelerations. And the H means head compression. Do you remember me saying that this patient with this strip was the Gravida 7 para 6? Yeah, that lady had a lot of babies. She was coming in huffing and puffing and going and blowing and the baby's coming. Well, if the baby's coming out, then the head is being compressed or pushed on with every single contraction. Remember, the contraction does two things, squeezes and pushes. Head compression, which is what strip letter C is where the contraction mirrors, the fetal heart rate deceleration, which means going down, mirrors the peak of the contraction. Like, it really looks like an upside down contraction. It mirrors it. It's very gradual. It's not sharp like the variables were. This variable was the patient who had low amniotic fluid and, you know, her baby was smaller, her belly wasn't measuring very well. She was a victim of domestic violence, okay? So these are two different strips. This is not good. This is actually really good, except you still got to do some stuff. You ready? Early D cells mirror the contraction. They mean head compression or that the baby's coming. And you better, are you ready? Have room ready and doctor or CNM in-house. In other words, call somebody. Your patient's going to be here and deliver, and she ain't going to have anybody to deliver her except for you, which happens. All right, so the E for early decelerations, the H for head compression, and the H for have the room ready. And get you a doctor or a nurse midwife in there, huh? Because what if I'm at the office and you have to call me and say, hey, I think your patient's getting close. Now, the H can also stand for this. Hand in vagina. Here's what that means. If you are a nurse and you're skilled and you've gone through your training, I see a patient with early decelerations, I'm going to put my hand in her vagina to see how dilated she is, right? I want to know, is she 9 centimeters while my doctor is like a freaking hour away? I got to know, okay? I've got to have my room ready. I've got to have my delivery table together. I've got to have the Chrysalmin, the baby bed warmer. I've got to warm that up with the blankets. I've got to turn on that oxygen and suction. I've got to be ready. There's a baby coming. We're about to have a birthday party up in this piece. All right. Next is the A and the O. Now, the A and the O, the A stands for accelerations, and I'm going to show you that in just a bit. So here we go. This A stands for accelerations, and this O stands for okay. O2 is good, right? Let's talk about that. Here we go. The Contractions are here. And let me just say, you don't have to have contractions to have fetal heart rate accelerations. But in this patient, they're in labor. Their baby has heart rate accelerations with or without a contraction. Let me show you. Here's an acceleration. Here's an acceleration. Here's an acceleration. Here's a great big acceleration. They're all fine. It's going up, right? The heart rate's going up. Remember what it's going up and how. It's going up 15 beats. It's lasting at least 15 seconds. And it's doing it at least twice in 20 minutes if it's an NST. If it's continuous fetal monitoring because you're in labor, we see these all the time. We know our baby is what? Okay. And oxygen level is good. This baby is very reassuring. So you don't need to do anything with the A and the O. Now let's make the A and the O bad. Let's make it bad. I'm going to take this purple heart rate, which had accelerations all the way through, and very nice, what we call variability. I'm going to make it look completely different and turn it into a bad thing. Here we go. I am doing the fetal heart rate completely different. In fact, I would even say this is the opposite of what I had up here. If you'll remember, I had this big, wild, wonderful, happy baby pattern. This is almost like a straight line. And you know in adults, straight lines are never good. But what is this in this baby, in this fetus? Well, you have five little things here on the board at the bottom. One is just me trying to make sure you know that a bradycardia is a fetal heart rate less than 110, but it has to last for 10 minutes. We don't let it go that far, by the way. Tachycardia is greater than 160. This, we absolutely have to see that for 10 minutes to call it tachycardia, because it could just be a fetal heart rate acceleration. Variability is how much movement beat to beat the baby gets. If it's a really great kid and it's just so happy to be here, this is beautiful variability. This is like a straight line. We would call that absent variability. There is no variation in the heart rate. It's kind of like a straight line. So watch this. Absent variability means O2 deprivation. What is the action? Give O2. So you can use the AO for good, which is accelerations, and we love that. Or bad, which is absent variability, medical emergency, baby needs oxygen, doesn't have it, maybe would be better out than in. Okay, so I hope that makes sense. Now let's do the worst strip on the board. Outside of absent variability, which is probably a good tie, let's look at this L and this P. The L, as you know by now, means late decelerations. I think I'm spelling these wrong. I got 2 C's in here. I think it's only one. Who gives a shit? And then the P stands for placental insufficiency. Okay, let me show you that. VL stands for late decelerations. I think it's only 1 C. And the P stands for placental insufficiency. Now let me show you what I'm talking about. When a patient has late decels, there typically is minimal variability in between, so there's not going to be this with late decels. So if you look, you can kind of tell what I mean. But the way late decels act, and I do want to show you the page in the maternity handout so that you don't forget. because it's kind of like an easy way to remember it. I just want to show you this real quick. If you've been following along in your handouts that you get when you do the self-study. If you look, this says early and late decels. And then it says, it's okay to be early for dinner, but don't be late. So it's trying to tell you that this is a problem. Look, late decelerations, what does that say? Indicate uterine placental insufficiency. There's that word. You heard me say it up here. Okay, so what we're saying to you is this contraction goes up. The heart rate gradually, not quickly, not abruptly, not quickly. No, gradually drops down. And even after the contraction is over, this kid did not recover. Watch this. I watched a lot of my friends who are doctors do this and nurse midwives, and then I found myself doing it as well. If we really want to make sure we're correct that it's a late decel, all we have to do is draw a line at the end of the contraction and go straight up on the monitor strip. And if you keep doing that, you'll see that this heart rate is still low. This fetal heart rate is still down. This fetal heart rate is still down. In other words, it's returning late. Yes, it started going down. And even after the contraction was over, which is when the baby should have recovered, it did not recover at all. It was a late recovery, late decelerations. It stayed down for quite a while. It stayed down here for quite a while. It stayed down here for quite a while. Oh my God, it's non-reassuring, first of all. It might be that this patient needs a C-section. Second of all, for one thing's for sure, something needs to happen. So let me tell you what you're gonna do. If we have uterine placental or placental insufficiency, you and I have got to know how to resuscitate that placenta. So uterine placental resuscitation is 5 things. And just in case you can't see it, I'm going to move that little phone down, that camera down. The first nursing action, change maternal position. Second is turn the oxytocin off if it's on. That'll just make matters worse. Third is give this patient some oxygen per facial mask and put that sucker at 10 liters. Fourth is open her IV fluids wide open so you can flood her uterus with fluids and resuscitate the baby that way. And keep her blood pressure where it should be. Last, you're gonna need to notify the nurse midwife and the doctor that all of this shit is going on, okay? Because they may need to come and do a C-section. So this is what we do. Now, in the rare instance that you have all this going on and it turns out that the patient also has tachysystole contractions, which is inadequate relaxation in the contractions, meaning less than 60 seconds rest between them, or what did we say earlier? More than 5 contractions in 10 minutes. That was a hint, or less than 60 seconds of rest between them. If your patient's doing all that, they may even need a little shot of terbutaline, which is a tocolytic, to slow these contractions down or just stop them. Give this baby time to recover. We're gonna be in trouble. Late decels are the worst. Okay, so I hope that that really, really helps. So look, bradycardia, tachycardia, variability, absent or minimal is distress. Acceleration's always good. Early, it's better to be early than late. And if you had variable decels, you're experiencing some cord compression, you still got to do something. So early decels are good because they mean a baby's coming. We're going to have a birthday party. I know this is a lot and I'm sorry, but it is what it is. And you got to know that maternity. So deuces, I hope you learn. God bless.